Hemophilia. This is another cause for bleeding tendency due to coagulation disorder. It occurs in approximately 1 in 5,000 male. No apparent racial predilection. It appears in all ethnic groups. We have either hemophilia A, which is due to factor VIII deficiency, and hemophilia B, or Christmas disease, due to factor IX deficiency. Both of them are the most common and most serious congenital coagulation disorder. The clinical features for both are virtually identical. Both of them are X-linked recessive, 30% due to new mutation. Hemophilia A forms 70%. Factor VIII does not cross the placenta, and so symptoms may appear in the neonatal period, while hemophilia B is 30%. Factor IX is usually low in the fetus and the neonate. So, if there is clinical manifestation in the neonatal period, re-evaluation should be done later on. The onset varies according to the severity. Severe one may appear as early as less than 1 year of age, moderate 1 to 2 years of age, mild between 2 years, and adult. Bleeding usually may be present at birth or may occur in the fetus. In the neonatal period, bleeding may occur from the umbilical cord. Intracranial hemorrhage may occur in 2% of male neonate. Post-circumcision bleeding may occur in 30%, and there may be bleeding at the site of intramuscular injection. Older children may suffer from muscle and joint bleeding when the child begins to cruise. CNS hemorrhage may be noticed in severe types. There may be post-surgical bleeding, oral hemorrhage after trauma causing torn frenulum, or after tooth extraction, which may persist for hours or days. Recurrent hematuria is quite common among hemophiliac males. Although bleeding may occur anywhere, but the whole manifestation of hemophilia is that of bleeding in the joint, hemoarthrosis. The hemoarthrosis may be induced by minor trauma or may occur spontaneously. The earliest joint to be involved is the ankle. As the child becomes older and adolescent, knee and elbow bleeding are also common. The early bleeding would be recognized after major swelling and fluid accumulation in the joint. Older children may complain of warm and tingling sensation in the joint. After repeated hemorrhage in the same joint, patient will develop target joint when the hemophilia is severe. Recurrent bleeding here may be spontaneous because of the underlying pathological changes in the joint. Frequent bleeding defined as more than 3 bleeds per month. This slide shows swelling of the knee joint due to bleeding within the joint. Muscular bleeding may occur with evidence of localized pain and swelling, but the most serious is bleeding in the iliopsoas muscle, which require special attention because the patient may lose large amount of blood in the iliopsoas muscle and pass into hypovolemic shock with only a vague area of referred pain groin. Clinically, the hip is held in a flexed, internally rotated position due to irritation of the iliopsoas muscle. The diagnosis is established clinically by inability to extend the hip joint, and it should be confirmed by CT scan or ultrasound. Concerning the severity, normal value of factor VIII and IX is 0.5 to 1.5 unit per mil. It means 50 to 100%. Mild deficiency when the level is more than 0.05 unit per mil. Moderate deficiency 0.01 to 0.05 unit per mil, and severe less than 0.01 unit per mil, which form the majority. The lab finding the bleeding time is normal, as well as the prothrombin time. while the PTT is prolonged and the level of factor 8 or 9 will go. Differentiation should be done from severe thrombocytopenia, severe platelet dysfunction as Bernard-Soler and Glasman thrombocythemia, type 3 von Willebrand disease, and vitamin K deficiency. Carrier detection can be done using intragenic or extragenic linkage analysis of DNA polymorphism. This is useful in 99.9% for detection, but only used when an affected male and his intervening family members are available for analysis. Alternatively, carrier detection could be attempted using determination of factor 8 activity with von Willebrand antigen. There will be decreased factor 8 activity to about 0.25 to 0.49 unit per ml, and a ratio of factor 8 to von Willebrand antigen less than 1 will identify 91 to 99% of hemophilia A carrier. Also in hemophilia A, prenatal diagnosis is possible doing chorionic villus sampling by 10 to 12 weeks or amniocentesis by 15 weeks of gestation, or fetal blood sampling by 20 weeks of gestation. The treatment is by replacement of factor 8 or 9 accordingly. 1 unit of factor 8 will raise the plasma level by 0.02 unit per ml. It means 2%. The half-life is 8 to 12 hours. It means factor 8 should be given either 8 hourly or 12 hourly. While 1 unit of factor 9 will raise the plasma level by 0.01 unit per ml, 1% with a half-life of 24 hours, so it should be given once daily. In general, 30 to 50% of normal factor are required for most bleeding episodes. 1 to 3 doses of factors supplement can control bleeding, prevent secondary hemorrhage, and initiate tissue healing. When there is life-threatening problem, surgical procedure or intracranial hemorrhage, a level of 50 to 100% is needed. To raise the level to 50%, the dose of factor 8 is 25 unit per kg, while the dose of factor 9 is 50 unit per kg. Another way of calculation, the dose of factor 8 equal to the percentage desired to raise the factor 8 times body weight in kg times 0.5, while in factor 9, percentage desired rise in plasma factor 9 times body weight times 1.4 or times 1. If the factors are not available, cryoprecipitate can be used for the treatment of hemophilia A in a dose of 1 bag per kg per day, which increase the level by 50%, while fresh frozen plasma in a dose of 10 to 15 ml per kg used for the replacement in case of factor 9 deficiency. DDAVP, the desmoprazine, given intravenously in a dose of 0.3 microgram per kg over 15 to 20 minutes, can cause a transient rise about 2 to 4 times rise in factor 8 and von Willebrand factor level by inducing release of factor 8 and von Willebrand factor from storage side. Be careful that DDAVP is used only in hemophilia A, not in hemophilia B. The doses are usually repeated 8 to 12 hourly, but an approximate 30% lower response may be expected after the second transient increase in factor 8 level. DDAVP can be given intranasally by intranasal spray in a dose of 150 microgram in each nostril, but the time to maximal rise in factor 8 level is usually delayed, and it is only used for mild hemophilia A. The antifibrinolytic agent stabilize clot formation is of value for oral bleeding. Epsilon aminocaproic acid can be used initially 5 gram orally or IV slowly before any dental surgical procedure, along with a dose of factor 8, will be sufficient to maintain the level, followed by a maintenance dose of 1 gram per hour post-operatively for several hours, until it is clinically appropriate to start tapering the dose over the next several days. Fibrin glue, useful for controlling bleeding in surgical procedure. It consists of fibrinogen, thrombin, factor 13 to cross-link freshly formed fibrin. It is of use mainly with orthopedic surgery. Humanized monoclonal antibody, the emicizumab, can bridge activated factor 9 and factor 10, thus restoring functional activated factor 8 activity in patients with hemophilia with or without factor 8 inhibitors. Once weekly prophylactic subcutaneous injection of emicizumab may be able to reduce the rate of bleeding in patients with or without factor 8 inhibitors. Prophylaxis. Primary prophylaxis is initiated with first joint bleeding. If target joint develop, then secondary prophylaxis is initiated. Prophylaxis is usually applied in severe hemophilia. Lifelong prophylaxis require central line to ensure adequate venous access. This program, although expensive, it greatly limits the degree of joint deformities. Factor 8 is provided in a dose of 25 to 40 units per kg every 2 to 3 days to maintain measurable level of clotting factor 8C 1 to 2% when assayed just prior to the next infusion. A newer long-acting formulation of factor 9 are available that extend dosing to every week or every other week. Supportive care is very important in toddlers. Mainly we should have car seats, belts, bike helmets, and avoidance of high-risk behavior. Older children should avoid violent contact sports. Aspirin and non-steroidal anti-inflammatory that increase the risk of bleeding should be avoided. Appropriate vaccination with hepatitis B is important, and routine or regular screening for hepatitis B, C, HIV, and liver function should be done. Chronic complication may occur. The most important is chronic erythropathy. The natural history of untreated hemophilia is that of cyclic recurrent bleeding into a specific joint, including hemorrhage into the same joint. It means target joint. In young children, the joint distends easily and a large volume of blood may fill the joint until tamponade occur or therapy in pain. Inflammation of the synovium occur. The synovium thickens, the cartilaginous surface become eroded and expose raw bone, leaving the joint susceptible to articular fusion. In older children, further bleeding into the joint with its thickened synovium causes severe pain because the joint may have little space to accommodate blood. The second complication is that of inhibitors, which is encountered in 25 to 35% of hemophilia A and 1 to 4% of hemophilia B. Highly purified factor 9 seems to increase the frequency of inhibitors. They are detected by routine screening performed once or twice per year in a symptomatic individual. Abrupt onset of unresponsiveness to the usual dose of clotting factors given for treatment suggests inhibitors. It is more common in severe type, black race, and members of the same family. For the treatment of inhibitor, several lines have been utilized. First of all, more frequent or continuous factor infusion cause loss of these inhibitors. Second, desensitization program in which high doses of factors are infused in order to saturate the antibody and permit the body to develop tolerance. Third, temporary removal of antibody by hemophilia. Fourth, the use of porcine factor VIII. 5. Bypass therapy using activated prothrombin complex concentrate that bypass factor VIII and IX for clot formation. 6. The use of recombinant activated factor VII in a dose of 10 to 15 units per kg, 1 to 3 times per week. 7th, immune tolerance by daily or weekly factor infusion plus low-dose cyclophosphamide, high-dose gamma globulin, and prednisolone. Rituximab have been used as an alternative therapy for patients with high titer of inhibitor who failed the immune tolerance program. Emicizumab may be another approach for patients with inhibitor.